All right, hello, Papalic guests, and welcome to Papalic's live roundtable discussion. I am Dr. Latasha Headley alongside my colleague, Dr. Ndukaku Amalu, and we are happy that you could attend our platform to participate in open and evidence-based discussions regarding issues affecting our local and global communities. Always remember to keep up with your reliable source by signing up at public.org. That's PUBHOLIC.org. And follow us on Instagram at www.instagram.com/Papalic. For more information on how you can join the Papalic family, we will place in the chat later our various links to connect you to us. This discussion today, I am extremely excited because we have the opportunity to host not only something that is very important, but we have our expert gastroenterologist, Dr. Daniel Anderson, to present and participate in our open discussion on colorectal cancer and screening. This is an important topic because, as the Centers for Disease Control and Prevention have stated, not counting some kinds of skin cancer, colorectal cancer is the third leading cause of cancer-related deaths in the United States. It is very important that our women and men alike all go out and get this screening. I will now turn it over to Dr. Amalu to introduce our guest speaker.
Thank you, Dr. Haley, for that warm introduction. Just what I'm going to read about Dr. Daniel Anderson, if we actually start talking about Dr. Daniel Anderson, that will be the whole 1 hour show, because what, what Dr. Anderson has actually done in California is amazing. And it's just an honor to have this humble, GI to be able to come to Papalic platform to be able to educate us in this field. Well, I have done a lot of work myself on colon cancer. And when I started doing this work, the only one name I was hearing is Tony Anderson. Tony Anderson, I'm like, who is this Tony Anderson? Until I met Tony. But he has done a lot of work in California. So I'm just gonna read a brief bio of Dr. Anderson. Dr. Daniel S. Anderson is a volunteer clinical professor of medicine at the University of California, San Diego. Since 1984, he has been a gastroenterologist with Southern California Permanente Medical Group in San Diego. He served as the chief of internal medicine for Kaiser Permanente in San Diego from 1986 to 2004. From 2004 to 2008, he was a member of the board of directors of Southern California Permanente Medical Group. He was the chair of the Southern California Permanente Medical Group's Colorectal Cancer Screening Guideline Development Committee from 1993 to 2004. Dr. Anderson was a graduate of the University of Arkansas School of Medicine. He completed his internal medicine and gastroenterology training at the Balboa Naval Hospital in San Diego. He went to become the chief gastroenterology at the Balboa Naval Hospital, San Diego from 1979 to 1984. 2007, he was appointed the chairman of the board of directors of the California Colorectal Cancer Coalition, which is known as C4, whose objective is to save lives and reduce suffering from colorectal cancer in all Californians. In 2008, he started Project Access in San Diego, which conducts Super Saturday, which were modeled after Operation Access in San Francisco in collaboration with the San Diego Medical Society Foundation and Kaiser Health Plan. Super Saturday provide outpatient surgical procedures and colonoscopies to individuals with low income and or uninsured people living in San Diego County. For this work with the uninsured in San Diego, Dr. Anderson was awarded the Public Health Champion Team Award by the County of San Diego Health and Human Services Agency in 2012. Dr. Anderson is on the executive committee of the California Dialogue on Cancer, which is called CDOC for short. CDOC is a dynamic coalition of people and organizations concerned with comprehensive cancer control in California. From 2010 to 2015, Dr. Anderson was the chair of the CDOC Executive Committee. Also, Dr. Anderson was one of the 2017 recipients of the American Cancer Society St. George Award. Dr. Anderson, it is an honor, like I said earlier, to be in your presence today, and Papaholic warm-heartedly welcome you in this platform at any time. Thank you for accepting this invitation and great opportunity to educate us on colon cancer. Thank you. You're welcome. I will turn it over to Dr. Headley.
Oh, I was going to ask Dr. Anderson, are there any words that he would like to say before we get started?
No, I just don't know who that was that was introduced. He sounds great, but no, that was a very generous introduction. And my main thing is I just want to save as many lives as possible from colon cancer. That's really what I'm interested in. So thank everyone for listening to this lecture in advance, and hopefully you'll be sure to be screened. All right, thank you.
Thank you. So we will move on. So before I get started, I do ask everyone to so kindly mute yourselves if you haven't already, just so that we can hear clearly the presentation, the questions being asked, and it will allow you to fully be prepared to participate in the roundtable discussion today. I will go over a couple of things, the discussion agenda for today. We would, of course, as always, Papaholic likes to define what the topic of discussion is. So we'll do that. We'll talk about the impacts of colon cancer in California by prevalence, incidence, mortality, population at risk. We will talk about types of colon cancer tests and frequency, best practices for prevention. And I am very interested to hear more about Dr. Anderson's work in promoting colon cancer screening in California, also informing us of what we can do to contribute to that promotion and colon cancer screening within our community. The objective today, Dr. Anderson will review colorectal cancer rates in California. He'll review how colonoscopy erroneously became the preferred CRC screening test. He will review evidence that screening for CRC with FIT is as effective as screening with colonoscopy. He will go over the best test is the one that gets it done, and illustrate ways our health care organization can increase CRC screening rates using FIT. But before we get started, I do want to make sure that we acknowledge Celine Morris, Dr. Celine Morris, Dr. Samir Gupta, and also Dr. Jim Allison. I now will turn it over to Dr. Anderson. Can you start us off by giving us a little background on colon cancer and screening and what that means?
Well, yes, and this is why colorectal cancer screening is the most effective screening for any cancer. And the reason is that colorectal cancer, as you can see on this slide, develops slowly from a polyp usually, and that can take up to 10 years. And these polyps that are likely to become cancer can be identified and removed, thus preventing cancer. And all of the screening methods we'll talk about can identify these polyps. And detection of early stage cancer allows for colorectal cancer mortality reduction. Since the 1990s, we've known that effective screening, and this was with fecal tests, shifts the stage of cancer to earlier stage cancers when they're discovered.
Yeah, so thank you, Dr. Anderson, for this. Based on this operational definition that you presented about colon cancer, can you please describe the impact of colon cancer in the US and California in terms of prevalence, incident mortality, and population at risk? probably also by gender, age, and race.
You bet. Yeah, I just wanted to go over this slide first. It shows by the screening shifting the stage of diagnosis. When you find a colon cancer that's localized to the bowel wall, the survival rate's 93%. And even if it's gone to gone through the bowel wall into a lymph node, you're still at almost 72% survival rate. And it's only when it's distant that you have a terrible outcome. So screening moves towards the regional and mainly to the localized cancers being found. Next slide. So this just goes through that that adenomas go into cancer, and it's rare because adenomas are actually very common. 22 to 58% of the people will have an adenoma during their lifetime. And about at age 50, about 25% of the US population will have an adenoma. So, and then over half of people will develop an adenoma in their lifetime. Next slide. So what are we talking about when we talk about the polyps? The polyp just means a benign tumor that protrudes into the lumen of the colon. An adenoma means that the cells in the polyp were derived from the lining of the colon. An advanced adenoma means that these are the significant polyps. They have to be large, either a centimeter or greater in size, or have villous features or other features of the way the cells look that shows high-grade dysplasia. They are not cancers, and their natural history is really unknown, but we know a little bit about them because we know about what percent go on to be colon cancer. And occasionally you'll hear the term colonic neoplasm, and that's usually advanced adenomas and cancers. Next slide, please. And go ahead and hit the slide again. How likely are polyps to kill you? Most polyps, even the advanced ones, do not directly lead to colon cancer. Only about 6% of these polyps will later develop into colon cancer. So that's only, as you can see on this slide, 2.5 per 1,000 polyps per year progress to cancer. And often I'll hear patients say, I had a pre-malignant lesion in my colon, and that referring to a very small polyp, and the chance of that polyp really becoming a cancer is extremely small. Even the large polyps, as you see, over a centimeter become cancer at a rate of only about 1% per year. And there was a study done before we had colonoscopy, because with the onset of colonoscopy, no polyp in this country was safe, and they were all removed. But before colonoscopy, they followed polyps with barium enemas, and a large polyp, and most of these polyps were at least 2 centimeters in size. They only had, after 20 years of malignant degeneration, of only 24%. And if you have a small polyp, and these are the ones less than 10 millimeters, and most polyps, 80 to 90% of polyps are less than 10 millimeters, it's very unlikely that you go on to colon cancer. So you don't have to worry if you do that first colonoscopy or you do that FIT test that we'll talk about later, and it requires a colonoscopy and you have a small polyp. That does not mean you're going to get colon cancer. Next slide. So go back one. The instance in California is about 1/10 of the United States instance, because we're about 11 or 12% of the United States population. So we'll be talking about California, but if you want to know what it's like in the rest of the country, you can just multiply by 10. And the mortality in California is over 5,000, and in the United States, it's 52,000. Next slide. So colorectal cancer is the second leading cause of cancer in men and women combined. So most of the times, American Cancer Society will say it's the third leading cause of death in women, because you go lung, breast, then colon cancer. And the third leading cause in men, if you go lung, prostate, colon cancer. But if you combine the sexes, which I like to do in being non-sexist, so that looking at men and women together, it's the second leading cause of cancer death in 2021. And it's most frequently diagnosed in older people, 65 to 74 years old. But we know that about 10% of new colorectal cancer cases are going to occur in patients younger than 50 years. And of interest, in adults age 40 to 49, it's increased by almost 15%. And you'll see the guidelines are taking this to account. And unfortunately, about a quarter of the eligible adults in the US have never been screened for colorectal cancer. And in 2018, 31.2% weren't staying up to date with their colorectal cancer screening. Next slide. So this is a predator, the colon cancer, the #2 killer. So who is the #1 killer? Of course, it's the alien, which I don't have a picture of on this presentation. But the alien, of course, is pancreatic cancer, or lung cancer is the #1 killer, but the real killing machine is pancreatic cancer. Next slide. As you can see, if you look at in California, breast cancer will kill 4,500 Californians, prostate 3,000. Lung is the big killer, 11,000, but colorectal, as you can see, is more than either breast or prostate. And pancreas will soon pass, probably pass colorectal cancer soon. It's a severe disease and we don't have good screening at this point. Next slide. So the instance, this is the California Cancer Registry has had good data since 1988. And so they're able to show in males a real decrease in incidence from 68 to 38%, and in females from 50% to 30%. And mortality also has decreased markedly from 27.3 per 100,000 to 14, and then in females 19 to 10 or 11 per 100,000. Next slide. And these slides will be available because you're not expected to have a test on this or remember all this. So you'll have this as a resource. And as you can see, as you age, your chance of colon cancer goes up very rapidly. Up here in the left-hand corner of this slide, there's something that bothers people. If you look at the 50-year-olds, their incidence is higher than the later, the 53, 54, 55, and even 56 and 57-year-olds. So this increase in the younger population has been very concerning. Next slide. But it also shows that slide, if we want to go back a slide, this slide shows why it's so important to make sure you screen people as they get older, because they have a much higher chance of having colon cancer that needs to be diagnosed early. Next slide. And so these are line graphs showing the decrease in mortality incidence rates. And it's a 43% decrease in males and 37 females since 1988. And our latest data we have from the registry is 2017. So a marked decrease in incidence rates. It was decreasing before we started screening, but screening really increased the downward slope of the line. It'll be very interesting to see what happens with COVID, since the screening rate has decreased during the COVID pandemic. Next slide. If we look at the different ethnic groups, we've worked hard. The African American group in California was much higher in incidence rates, and we worked hard to increase the screening rate in the African Americans. But yet the African Americans, with perfect screening, you can reduce it to the white non-Latinos. The Latinos are about the same as whites. Asian Pacifics are a little less. And what's very disturbing is the high rate in Native Americans in California. Next slide. And here's the incidence trends by age. If you look at the 50 to 64, and this was a very concerning, the slope of the line is much less than over age 65. So we're doing a much better job of screening over age 65 than we are 50 to 64. Next slide. But here's what scared people. The younger population, the incidence rates are much less per 100,000. If you go back a slide, the upper limits on this one is is 80, and the upper limits on next slide on the younger age is only 4. So this is a very low instance, but it's increasing, and it's increasing in the 35 to 49-year-olds. Next slide. And here's the other thing about instance that we are concerned about in California. If you look at the white non-Latino, you've had a good drop in instance rates from 1988 to 2017. And in African American, you have a similar drop, even greater in females. Latino, much less, and we know our screening rates in our Latino population is less. And in Asian Pacific Islanders, our screening rates are less, and the area that we're most concerned about are our Native American population, who have had actually a significant increase in incidence rates in females. This increase is not significant, but this one, the 73%, is significant. Next slide. So let's talk about mortality. Once again, mortality has been decreasing for a variety of reasons. So the decrease became steeper with good screening, but it was already decreasing, and we're unsure about the causes for this, but we're thankful for them. Next slide. And if you look at the mortality rates, once again, everyone is about the same except for this increase in Native Americans and this unexplained mortality rate in African Americans. And this is this increase in mortality in African Americans once they get the disease is still there when you get proper surgery, when you get proper chemotherapy, and you get up-to-date treatment. So the disease is worse in African Americans once it develops, and it just points out why it's so important for African Americans to be screened and reduce their incidence of colon cancer, which you saw on an earlier slide, they're able to do where they're in line with the other ethnic groups. Next slide. And so what we've seen in California, we've seen a marked reduction in mortality, and even a marked reduction in mortality, mainly in females. And actually, females are more likely to be screened in every population. And Latino, we've not seen as many. The reduction is great, and the screening rates aren't as high. And Asian Pacific Islanders are sort of in the middle. But once again, our Native Americans, especially males, are having an increase in mortality. And it's a significant increase, whereas the increase in females didn't rise to the level of significance. But this is it's a problem. Next slide. If you look at late stage diagnosis, which is a sort of a hard line way to look at screening, because we know that screening shifts the stage away from late stage diagnosis, and the cancer registry uses everything except totally within the wall as late stage diagnosis. So even the regional spread is considered late stage diagnosis. And if you look at Medicaid, you're at 71% compared to Medicare at 63%, and the military at 66%. And the shocking thing on this 5-year snapshot from 2014 to 2018 is that the uninsured actually have a better late stage diagnosis than our Medicaid population. And as we'll talk about later, we don't know what our screening rate is in our Medicaid population because they are not required to measure it. And there's been some progress in that just recently. All right, next slide. If you look at disparities between ethnic groups on late stage diagnosis, we really didn't see any. In our cancer plan that we are just getting published, our disparities goal in colorectal cancer in California was to decrease a late stage diagnosis in Medicaid, not any ethnic group. And you see males and females are almost identical. So there's no significant differences here. Unfortunately, the unscreened population, as you would think, the 20 to 49-year-olds do have a higher late stage diagnosis than the screened 50 to 64 and over 65. Next slide. So percent late stage diagnosis in California, Medi-Cal, as I mentioned, is higher, and also the low socioeconomic status is higher, and that goes with the Medi-Cal insurance. Next slide. So screening for colorectal cancer. Fortunately, when we scheduled this conference, the U.S. Preventive Services Task Force hadn't made their recommendation for 2021. And here's what they're saying, is that they've now moved the screening age down to 45, who are at average risk, and you can see on this slide what average risk is, and they're recommending screening for this group. Next slide. And so they recommend screening for colorectal cancer aged 50 to 75, and this is grade A. So excellent evidence that this works. But grade B means there's excellent evidence, but not to the strength of grade A. They recommend screening for colorectal cancer age 45 to 49, and that is a new recommendation. So that will increase the population that needs to be screened, but this is, as we've mentioned, a high-risk group that their incidence is going up. And then if you're over age 75, which some of us are, you can be screened. What this comes down to is if the life expectancy is really over 10 years, then go ahead and be screened. And also, if the person hits age 76 and has never been screened, it's certainly worth screening them between 76 and 80. Okay, next, I think that's a time for a question now.
Yes, I have one for you. Well, considering the screening age recommendations, can you also tell us about the types of colon cancer tests and frequency of these tests?
What the screening will be? Well, that's a perfect introduction to our next slide, which is up. So these are the recommended screening strategies by the U.S. Preventive Services Task Force. And this FIT test is a fecal immunochemical test. The high sensitivity guaiac tests are almost never done anymore, but the FIT test is the most common test of the fecal tests. And in the rest of the world, it is the major screening test done, period. So you'd have to do that every year, and we'll talk a little bit later. Once you start doing this test, it looks like you don't mind doing it again and again and again every year. The new stool DNA FIT test, which everyone on the call knows because it's Cologuard, which is advertised heavily in every media outlet there is. And they changed this. They were saying it should be done every 3 years, and this interval for testing was based on almost no evidence because there's been no long-term trials of FIT DNA. And now they're saying it's every 1 to 3 years. The virtual colonoscopy, or the computerized CT colonography, is recommended every 5 years. And this one, of course, if you see a polyp, you have to have the colonoscopy. A flexible sigmoidoscopy every 5 years. And then a flexible sigmoidoscopy every 10 years with an annual FIT is also another option. Unfortunately, in this country, getting a flex sig is actually fairly difficult because it used to be done by primary care physicians, but now these scope cleaning requirements, it's pretty well done in GI suites and in hospitals, and in general, they're doing colonoscopy, which is the last screening test, colonoscopy every 10 years. Next slide. So if you look at these tests, and they do this CISNET model, and this assumes perfect screening, and there's about 30 deaths per 1,000 unscreened. So all of these markedly reduce cancer deaths. The FIT test every year, and the confidence intervals on all of these actually are overlap. So they're all considered equal screening tests. The FIT test every year, the fecal DNA every 1 year or every 3 years, the CT colonography, the SIG, and so on. So they're all equally effective. Next slide. So this was important. In the new U.S. Preventive Services Task Force, they said during the test and follow-up procedures for abnormal findings on the screening test. So as part of the screening process. They said that the follow-up after an abnormal fit, which means there was blood in the stool or a DNA or a flex sig or a CT colonography. So the positive results on the stool-based screening test require a follow-up. They used to call this a diagnostic colonoscopy, and that's important because of cost-sharing problems.
Thank you so much, Dr. Anderson. Now, based on your professional experience as a GI specialist that has done this for, so many people and in clinical setting, can you briefly describe what type of symptoms do people have when they're experiencing colon cancer, diagnosis, misdiagnosis, if any, and management and treatment?
Okay, we're talking today about asymptomatic people, and that's very important, especially if you're younger than now age 45. So the screening tests are for asymptomatic people. If you have blood in your stool, you're going to have a colonoscopy at any age, or at least a flexible sigmoidoscopy if it's bright red blood and you're under age 40. So when you have symptoms, the tests necessary become diagnostic tests. So if you're having severe abdominal pain, crampy abdominal pain, rectal bleeding, then you don't need a screening test, you need a diagnostic test. We're talking today about screening, and as on one of those earlier slides, these are people without symptoms, without a history of polyp, without a history of inflammatory bowel disease, and with a negative family history for colon cancer. If you have symptoms, and this is especially important in the people under age 45 that aren't getting screening nowadays, then you need a diagnostic test. If you're having bright red rectal bleeding in a young person, and this is probably the most common thing that happens, and your physician says, well, it's probably from hemorrhoids or a small tear in the rectal mucosa, that's not a good enough assessment of that symptom. You need a look. You need to look with a colonoscopy or at least a flex sig for bright red rectal bleeding to make sure there's not a tumor just inside the rectum. So I think that answered your question. So we'll now talk about the different tests and why and which ones should be used. They're all good tests, so I'm not against colonoscopy. Colonoscopy, if you go back one slide, became Katie Couric made it where it was the test to do in the early 2000s because she actually had her colonoscopy done on TV. And next slide. But we know that deaths from colon cancer reduced from 50 to 80% with colon cancer screening. There's never been a randomized controlled trial of colonoscopy screening to show that it was effective, but we have level 2 evidence. No study has shown. For a little while, the American Cancer Society was saying you have an 80%, 90% reduction in deaths with screening. Well, that's just not true. We know that colonoscopies, and anyone that's done a lot of colonoscopies like I have, we know that we miss polyps 6 to 12% of the time, and then we can miss a colon cancer 5% of the time. Next slide. There's, as I mentioned, no randomized evidence of that colonoscopy reduces mortality. There is good indirect evidence. And the mathematical modeling that's used for all of the screening tests shows it's an excellent test. So it's an excellent test. Next slide. The other test is the fecal immunochemical test. You got to see all my slides there for a moment, but I hope you didn't read it. So it uses antibodies specific for human globulin, and it's specific for colonic bleeding. So for the old guaiac test where you had to change your diet, you don't have to change your diet. It's FDA approved. It's reimbursed by CMS. And it allows for quantification of how much blood is in the stool. And that may become important in the future. Right now, there's a cutoff that's about the same for everyone. It's at the level of 200 micrograms per gram. And if it's above that, it's a positive test. And it can be read and developed by technicians or as we do in Kaiser, automatic readers that can develop thousands of tests a day. Next slide. So it's very, we'll talk with this, the PolyMedCo. This is the most commonly used FIT test, and its sensitivity for cancer is 84%. This is on one time, one pass. And as you remember, it's done every year. And as I'll mention later, and I'll mention now, there are 3 randomized controlled trials that are about halfway through that are comparing colonoscopy to FIT testing. We do not know the results yet. And the nice thing on the FIT test, it does pick up the adenomas, it picks up those at 33%, very specific. And so that's the point of this slide. Next slide.
Thank you, Dr. Anderson. I think then in the next section, we would like you to explain what some of the best practices for prevention as it relates to achieving your high screening rates.
Absolutely. And this is probably the meat of the talk. So when you have a person's average risk for developing colorectal cancer, and this was done in the San Francisco area with an ethnic, racial, and ethnically diverse population, a lot of Asian Americans, and they were to receive, they had 3 groups that would come in, and they would recommend screening by either the fecal occult blood testing, colonoscopy, or their choice between fecal occult blood testing or colonoscopy. They had at least almost 1,000 were enrolled, and 58% completed the colorectal cancer screening. And John Inadami did this, who's a leader in our field. He's now the chief of medicine in Utah. Next slide. And as you can see, more people chose to do the FIT test at home. And in the COVID periods, this is really the main thing we've used during the COVID pandemic. If you just offered the colonoscopy, only 38% did a colonoscopy. But if you offered both, you had the highest level of participation, where you got almost to 69%. Next slide. So the conclusion that he came to, the common practice of just recommending colonoscopy reduces adherence to colorectal cancer screening. What you need to do is make sure that you offer a menu of tests of the FIT test or the colonoscopy. Next slide. So will people continue to do the FIT test? This was a large Kaiser study. Almost 1 million people were offered FIT. We usually get about 50% returns on our FITs. And then of the 48% returning, 75% return the second one. And once you got used to doing it, which is quite easy to do, just put a piece of paper in the toilet, have your bowel movement on the piece of paper, put the probe in it, put it in the container, and mail it in. 83% were in the 3rd round, 86% the 4th round. As always, they're going to have about a 5% positive rate, so they get crossed over to the necessary colonoscopy. Next slide. So FIT does have advantages over colonoscopy. It's inexpensive, it's easily obtained, can offer by any member. You set up your clinic to where when people come in, if they haven't been screened, they get educated on how to do the FIT test and why it's important. And that can be done by an MA, not necessarily the doctor. It's non-invasive, no risk of pain, bleeding, or bowel perforation or other adverse outcomes. And it only requires a colonoscopy if abnormal, but it absolutely requires colonoscopy if abnormal, because you have about a 5% chance of having colon cancer if it's abnormal. And the best thing about the FIT test is, as we showed, patients prefer it. Next slide. So the screening strategies are yet to be completed. And modeling that for years life saved through annual high quality stool blood screening program is comparable to a high quality colonoscopy based screening program. So you are not offering a patient a lesser strategy. And that's very important, because for a little while there, right after Katie Couric in the early 2000s, FIT testing was considered to be a less of a test, not the preferred test, but everyone, the National Colorectal Cancer Roundtable, American Cancer Society, and all our professional organizations realize that FIT testing and colonoscopy are both excellent tests. Next slide. And which FIT tests? The OC Lite or the OC FIT Check, or it's a PolyMedco FIT test. And here the other is the one that has the most data behind it. So this is just a resource slide for you if you're working on setting up a screening program. Next slide. Now the DNA FIT has improved sensitivity. This is Cologuard with one application of screening. The specificity is lower than FIT, so you'll have more false positive results. So you have more follow-up colonoscopies. And in a recent study, you have almost 18% positive. So that means almost 1 in 5 will have to get a colonoscopy. And the modeling suggested that the screening of every 3 years didn't provide a favorable balance of benefits and harms compared to screening every 1 to 2 years. And this may be problematic because the FIT test costs about, in big systems, about $5, and smaller systems about $10. The Cologuard costs in excess of $500, so it's much less cost effective. And we don't know about the longitudinal follow-up of abnormal findings after a negative follow-up colonoscopy, because this checks for tumor DNA that could be coming from other than the colon. There's no direct evidence on the DNA FIT on colorectal cancer mortality. There's only one study really that showed the sensitivity, which was better than a FIT test, and it's less cost effective. So this at this point is a second line test, but it may, with improvements and time, become equivalent to the FIT test. Next slide. CT colonography. It's very accurate in detecting colorectal cancer and adenomas, but if they find a polyp, which they do, as I mentioned earlier, most of the time you have to go ahead to the colonoscopy. And there's no direct evidence that CT colonography affects colorectal cancer mortality, only on mathematical modeling. And the main problem is extracolonic findings are common, and the extracolonic findings are detected in almost between 1 to over 10% of the exams, and about 3% will require medical or surgical treatment, and very few of them actually affect the health of the patient for these extracolonic findings. For this reason, CT colonography has been used mainly in people that are unable to do a colonoscopy, and you really need to look at the colon. So it hasn't caught on as a screening test at this point. Next slide. Flexible sigmoidoscopy. There's good evidence from randomized controlled trials in England and in this country that it reduces colorectal cancer mortality. It's less risky than colonoscopy, but it's fewer life years gained alone when compared with FIT or with colonoscopy. And it's extremely difficult to get a flexible sigmoidoscopy in the US.
Yeah, so sorry everyone, I didn't even realize my video wasn't on somehow, but it's okay. So thank you, Dr. Anderson. I know you personally and the work you've done, and many people from our audience do not know you. Can you please tell us about the great work you are doing or you have done in California to promote easy access for every Californian to screen for colorectal cancer?
Yes, on this slide, I don't have this, but C4, this California Colorectal Cancer Coalition, has given out almost $700,000 in small grants to our federally qualified health centers, which screen at about 46%, and that's good for the country. But we give them small grants to increase their screening rate, and we've been doing this for almost 7 years. So the other thing we're doing has to do with advocacy, and we have a assembly bill we call our House, which we call it the Assembly, an Assembly bill introduced by Mike Gibson, our Assemblyman from the LA area, would get rid of the co-pays or the cost sharing after a positive fit. So there was no downside to doing a fit test, that when it required a colonoscopy, it used to be that insurance companies could charge you the cost sharing for that colonoscopy. This would get rid of that. It passed out of the Assembly last week, 70 votes positive, no votes against. It's going to the Senate, and we'll make sure it gets through the Senate. But a bigger deal, one of the medical directors of a federally qualified health center in San Diego was jealous of how Kaiser, wanting to be a Medicare 5-star plan, had really invested in colorectal cancer screening in our medical group. And we are a 5-star plan because we increased our screening rate from the 60s to over 80, but it was with the help of the health plans. So he said, why doesn't Medicaid, which we call Medi-Cal in California, why don't those insurance carriers promote colorectal cancer screening, which they did not and still do not. And the reason is they don't have to measure it. They don't have to report it as one of their quality measures in Medicaid. So we just recently, about 2 weeks ago, got CMS, the voting group that recommends additions to their quality measures, to recommend the addition of colorectal cancer screening, which will be part of their quality core measures in 2022. And this is a big deal. This will affect every Medicaid program in the country because most of the Medicaid programs do the cancer screenings. And the only 2 cancer screenings that are in their core quality set right now are breast and cervical cancer. So soon it'll be colon cancer in 2022. So we're real proud of that. And that's what we've been doing in California.
That's amazing. Thank you so much for sharing that. And I will turn it over to Dr. Headley to take us into open discussion so that everyone can comment or ask questions and participate.
Thank you, Dr. Amalu. But before we go into the open discussion and I stop sharing the screen, I always like to offer our guest speaker, if Dr. Anderson has anything that you'd like to summarize or, take us home with, just key things to remember.
Well, as we discussed before I started, we've got maybe, 70 or so people are going to be watching this. And if all 70 of the people that are watching this make sure they're in a screening program, it'll prevent one of these 70 people from dying from colon cancer that would have. So screening, colorectal cancer screening is that effective. You only have to convince 70 people to start a screening program and you'll save one life. That's actually incredible.
That is awesome. Well, I thank you for your lovely presentation. I've learned a lot about, colon cancer, and also not just that, the different types of screening that can be done. I'll wait for the open discussion, but I'll just leave it with the FIT screening. I do understand how that would be more appealing, especially during the COVID, these COVID times. And I would be very interested to see what the data shows as a result of, post-COVID, what the data shows as far as the screening and so forth on that. So
yeah, it'll be very interesting. We had some federally qualified health centers that during COVID actually increased their screening rate by using mail-out FIT, whereas everywhere else in the country, screening rates plummeted because they were mainly colonoscopy based, which was suspended early in the pandemic. Screening colonoscopies were suspended. They just weren't done.
yeah.
Yes, and I would, let me pose one question to Dr. Anderson, and I'll leave it for every other person to pose. So many of us that are in here know, and I hate to bring this up, but I needed to bring it up so that maybe people will understand how what, the temerity of the importance of screening. Chadwick Boseman died of colon cancer or colorectal cancer last year. Chadwick is a well-known, one of my favorite actors. He did a lot of movies, and one of the best movie he did is Wakanda movie. He died at age 43 for this disease. Diagnosed with a stage 3 colon cancer in 2016, which if you look at the age, it will be approximately around 39 years old. And he battled this cancer for 4 years, battling it as he progressed to stage 4, and he finally took his life. We miss him. To get to stage 4 or to get to stage 5 could be a matter of years. And you have said it earlier, about 10 years, just as it progressed. So I know there is also many parameters that influence progression of cancer, but on average, based on your experience, how many years do you think it would take a polyp to go from stage 1 to 2 to 3 and then stage 4? Because I'm thinking, okay, if he died at 43 and if he got diagnosed as stage 3 at 39, he could have had this in his mid-20s or maybe late 20s, so that's why I'm bringing this up.
Yeah, he was a real tragedy, and even the new screening recommendations wouldn't affect him. And you're right, he probably had polyps in his 20s. And I don't know that his family has released a lot of his medical information if he had genetic testing to see if he had the Lynch gene, which Lynch syndrome is a genetic syndrome that causes early onset colorectal cancer in anyone that has the gene. And I don't think he had familial polyposis, which would also causes hundreds or thousands of polyps in the colon, but we just don't know. But he certainly had a polyp earlier in his life, and we don't know if he had symptoms that weren't evaluated, but it was a real tragedy. And
Yes.
I think it points out that if anyone has symptoms at any age, you just have to have them evaluated. So, and that hopefully will prevent many other tragedies like his.
Yeah.
Yes, thank you. And there's one question from the chat and a statement. It says, with the increasing numbers of the prevalence or incidence of CRC seen in Medi-Cal program, to what degree does this reflect the Medi-Cal impact on CRC? Are there any implications of lessons learned from your studies on CRC screening in California, especially as it affects Medi-Cal clients?
Well, that's an excellent question. We've been concerned about the fact that Medi-Cal doesn't really know what their screening rate is for years. We had Oregon, which is just to our north, that started measuring their Medi-Cal screening rates, and they were in the 40%, and they markedly increased them. And so their federally qualified health centers screening rate is now past ours when it was lower. So we know it's low in Medi-Cal. We know it has not been a high priority in Medi-Cal. That will change because there are already now some conferences that we're setting up with the Medi-Cal providers like LA Cares, like HealthNet and others. There are 4 major Medi-Cal carriers, and we're having a program with them to talk about how they can increase their colorectal cancer screening rate and also measure it. So this is going to change, but it just shows you that your public health people that the policy of not measuring colorectal cancer screening in Medi-Cal, because it started mainly as children and women, has had a big influence in California, so that the biggest disparity we had when we last looked at it was the type of insurance you had. So if you had Medi-Cal, you had more late stage diagnosis. So we're going to correct that. And Medi-Cal will want to correct it. And Medi-Cal managed care in the California Department of Public Health will want to correct it. So everyone's on the same page. But we just have to measure it first. Okay.
Thank you for that. Are there any other questions? I don't see any in the chat, so I'm opening it up to everyone. Just unmute yourself and ask away.
I have a question.
Hi, Dr. Headley. I have a question.
Sure.
This is Florence Njang. I have a comment, first of all, for clarification, and then I'm going to ask a follow-up question from the response from Dr. Anderson. If I may understand you correctly, is that when you have colorectal cancer, when you have a family history, is your colorectal screenings decreased to every 5 years or every 3 years?
In general, it's every 5 years. This lecture really wasn't on increased risk, but if you have a young primary relative, you start screening early. And if you have more than one primary relative with colorectal cancer screening, you probably need to undergo an evaluation to make sure you don't have the Lynch gene, which that screening for that sort of family history starts off at 2 years, but ends up at every 1 year colonoscopy. So family history is important. It means you're at high risk. You have to start screening 10 years before the age of the relative that got colon cancer. So if they got it in their 50s, you've got to start in your early 40s. And the usual interval is 5 years, but if a polyp is found, then obviously the interval decreases based on that polyp.
Yeah, thank you, Dr. Anderson, for that response. Okay, based on the new recommendations from the United States Preventive Service Task Force that has decreased the initial age of screening to 45, is there any way they can also decrease the frequency of screening for colorectal cancer and even the flexible sigmoidoscopy? If for instance, you say, I have a family history of colorectal cancer because a family member or a parent had it, and I'm 45 years old now, means I qualify to start screening 10 years before age 45. Is there any way to push forward to recommend an earlier screening? Say I had to start at age 35. Is it possible to start at age 30?
Well, if your family member developed colorectal cancer at age 40,
right,
then you would start, your healthcare provider, if he follows the guidelines for high risk, would start your screening at age 30. But your family member would have had to have developed colon cancer at age 40.
I see. Okay.
You didn't mention the age of your family member. And
Okay.
it should be a primary member. The average risk screening recommendations have a lot of data behind them. Screening recommendations on increased risk from family history are much more problematic. That's why the U.S. Preventive Services Task Force shies completely away from issuing guidelines on increased risk. It's just for average risk.
Okay. Okay. So also the other question I have is there increased risk from a flexible sigmoidoscopy compared to a colonoscopy? Because patients have complained that there's a lot of pain that is involved in this flexible sigmoidoscopy if you are not sedated. So,
Yeah.
but for the, go ahead, Dr. Anderson.
Well, the FlexSig, yes, it's very interesting. Like as I mentioned, there's almost no screening is done with the FlexSig anymore for one of the reasons you mentioned, that it's a non-sedated procedure.
Right.
So it's just as almost fallen off the map, but it still has a lot of scientific data from other countries, mainly England, that it's an excellent screening test. But if you went out to try to find someone to give you a FlexSig, it would be a little bit difficult for you, whereas getting a colonoscopy would not.
Okay.
Thank you,
Thank you
Florence,
so
for
much,
your
Dr. Anderson.
question. Thank you,
Okay.
Florence.
You're welcome.
George has a question. He asked, is there a direct, or he's rewriting it, huh? Is there go ahead, George, you can speak.
Yes. Is there any direct relationship between breast cancer and the incidence of colonoscopy? I mean, Colorectal.
cancer. In general, there isn't, but in some genetic testing, there's overlapping genes. And so it would be a person that was getting genetic testing. In general, having a breast cancer in a close relative doesn't increase your risk of colon cancer.
Okay.
It's interesting, you all are asking the questions away from average risk, but that's what everyone's interested in. I understand it.
Then in terms of Africa, the high incidence of this type of cancer among African male, what is the causation? Is it hereditary or maybe something like diet or socioeconomic status?
I don't think anyone knows for sure. So
Wow.
we don't know. It has to be genetic, obviously, but it's not the preventable causes, because there's been a good study where they made sure people got their surgery on time, make sure they got the proper chemotherapy, made sure everything was done the same as the control group, which were other ethnic groups, and yet the mortality was still slightly higher. So it's a problem probably in genetics.
Teresa,
Thank you, sir.
You bet.
Go ahead,
Teresa,
Teresa.
thank you so much, Dr. Anderson, for the informative section. I truly, truly appreciate your time, as well as giving us some cutting edge information. A lot has been said, and we've learned a lot from you, as well as some existing literature out there. But we still have a huge gap in terms of behavior, attitudes towards health-seeking behavior, especially among minority ethnic group. And the struggle continues, and the awareness is there, but bridging the gap to enable people or to get people to be motivated to, go for screening for early detection and opportunity for modality with treatment is still a huge problem. My question though is, what level of planning is in place to improve health-seeking behavior, knowing the risk and the vulnerability of risk among population health, more specifically people in the minority population? Thank you.
Yeah, I'm not an expert in the area of disparities, but, and as I mentioned, in California, our main disparity was between ethnic groups, wasn't between ethnic groups. And we did work with our federal qualified health centers, especially ones that took care of mainly ethnic minorities, to ensure that everyone got the information on colorectal cancer screening. And most of them took the FIT test, as in the study I showed. And we were able to get our incidence of colorectal cancer in African Americans almost the same as every other one, but not the mortality. So it can be done. You would have to concentrate on it. You have to make sure you have the education for everyone that comes in, regardless of ethnic group. And, but there's been other studies that I'm just not as well versed on. And some of them, it was interesting in African-American communities, if you make sure that in the barbershops, colorectal cancer screening is discussed, you can increase colorectal cancer screening. So there are ways, and I'm sorry, I'm just not an expert in how it's done, except in the clinics. And in the clinics, it just means everyone that needs screening needs to make sure they have the information. And we found that all of the ethnic groups will do the FIT test. So that's what we've done. Sorry, I'm not an expert in disparities, but
That's fine. Thank you.
I work with Dr. Fola May at UCLA, and she is, and a few others. But.
No, I very much appreciate your answer, because grassroots involvement is just an area. But thank you so much. Appreciate your response.
Okay.
Hi,
Thank you,
Dr.
Teresa.
Anderson. Hey,
Oh, go
Dr.
ahead.
Hedwig. Yes.
Yeah, go ahead.
My name is Susan Oku. Thank you, Dr. Anderson, for this presentation. It's so informative. And my question is just, and comment as well, is just about the fit test. I'm a nurse. I never even heard about the fit test till now. So
I know that's a big problem.
so I
Gotta
had
come on the East Coast.
I know.
Well, the
I
East
had
Coast, you're right, the East Coast is more than the West Coast colonoscopy based. It's very interesting. Kaiser, who I work for, we realized that the fit test was the way to go years ago, back in about 2005. So, but the East Coast is colonoscopy based. South is too. Anyway.
Okay. So my thing is that I had colonoscopy done a few years back and it was negative. And they told me that the next time to check it again will be in 10 years from the day that I had it, the year that I had it.
Yeah.
And I'm thinking that's good, but still something could happen between then and in 10 years. Do you think involving this test as a bridge will be good for people that will take so long before they recheck the do the screening? Mine was like colonoscopy screening.
You point out the main problem with colonoscopy screening is the frequency, and the 10 years is what's recommended. So people aren't recommending less than 10 years. And so far, we haven't seen the studies, but some studies are being done in doing interval fit testing between the two colonoscopies to see if that is effective. But there is no data to guide you scientifically about what to do. It's every 10 years. And that has really reduced your chance. The single negative colonoscopy really reduced your chance. But we just don't have data on doing anything different than what the U.S. Preventive Services Task Force has modeled out. So.
Thank you.
Are there any other questions?
But Susan, I think, has one.
Yes.
Oh, she just asked it and she has her hand raised still.
Oh, okay.
Oh, wait, let me look at the chat. I think in the chat.
I think
has a
Ronnie
question.
wants to ask a question. Go ahead,
Hello
Ronnie.
and thank you. Hello and thank you, Dr. Anderson. I got a lot out of your presentation. I actually have a number of questions, but I know time is really kind of short, so I'll just come to the main questions I wanted to ask. The screening test, the FIT versus the diagnostic one, the colonoscopy, you guys just indicated that that test usually is recommended every 10 years. But here is my question, and I'm asking this question because I know of someone that has recently gotten the FIT test that came back negative. And yet the person has occulted blood in their fecal matter. And from what he told me, it tends to occur, that is, where he sees blood in his fecal matter at specific times of a month. It's like within any given month, let's say that date is around somewhere between the 20th and the 25th. From what he told me, it tends to occur every month around that time. And yet he has
You're
no.
saying he tells you that?
Yes.
He, but so in a woman that you would worry about endometriosis that was embedded in the colon wall that was bleeding once a month. But in a man, that's not available. So what the question you're asking me, it's very interesting that he is no longer asymptomatic. He has seen blood in his stool.
Right.
So he really has no choice. He's got to get a colonoscopy.
Right.
It's not It's not occult bleeding anymore. He sees blood. So
From what he was telling me, I think what discouraged him from getting the colonoscopy was the fact that his FIT test came back negative.
that's
I
right.
know, I
It's a
know.
fit test can miss blood. There's no question. And if he
Right.
saw blood, that automatically colonoscopy.
Excellent. One last question. In reference to the sDNA test, correct me if I'm wrong, but you had mentioned something to the effect that the DNA that is identified in the colon may have actually had its origin in another organ system.
That could get in the
If
stool.
that,
Yeah.
right,
The recommendation
that,
is, the recommendation, I think I know your question. How much workup do you do to look for those other tumors if they're possibly there?
right.
Right now, there is no recommendation to do anything more than the colonoscopy. And the reason for that is when the Cologuard or the FIT DNA test is positive, they don't tell you, was it the DNA or was it just like a positive FIT test? And we know that blood can get in the stool for a variety of reasons other than a tumor or a polyp. So the idea is that it was just a false positive and you just have to do the colonoscopy. That's where we are now on that. That makes sense?
Thank you so much, Don.
Yeah.
Yes, it does. Thank you so much.
Yeah.
Thank you, Rodney, for your question. Does anyone else have anything to say or ask? Statements, anything?
Yes, one more last question from
All
our
right.
Does diet have any impact in terms of this incident of?
Well, you're asking about primary prevention. That is a big subject. Yes, we think that that if you like carne asada, or heavily grilled charred meat, that's not good for you, and that can increase colorectal cancer. That a high fiber meat and vegetables, fruits,
Exactly.
healthy diet decreases colorectal cancer. Taking aspirin for cardiac reasons decreases colorectal cancer. They don't recommend taking aspirin just to reduce colorectal cancer. Yeah. But primary prevention is a whole nother lecture. And once again, I know a little bit about it, but I know that a healthy diet does decrease colorectal cancer.
So there has not been any study comparing diet, maybe people that live on vegetarian type of diet and people that live in urban area with meat?
The main one is the charred meats that has shown an increased risk of colon cancer. That's the studies I'm aware of.
Thank you very much.
Probably are others, but I'm sorry.
Very grateful for this information.
You bet.
Now that you brought that up, Dr. Anderson, that's a good topic of discussion for another time. That I'm interested in because we do promote healthy nutrition on our platform as well. So that would be very interesting to have a few speakers on that. Before I close out, I like to just be courteous. Is there anything else that anyone would like to add before we close out? This was a very, very good discussion that I truly enjoyed. And it can take so many avenues, but I think that Dr. Anderson was very concise on giving us the immediate necessary information that we need and that we can share with our loved ones, friends, acquaintances, whoever, on this to promote going out and getting testing and taking care of themselves overall.
Yeah, Dr. Haley, I have a question for Dr. Anderson. Yeah, I looked at the charts that he presented on private pay and Medicare, and the rates were kind of different. Can he throw a little light on that? Why is the private pay less than the Medicaid? Is that because people have to pay out of pocket and it's a burden to release finances? I need some.
The private insurance has a lower late stage diagnosis, and private insurance your commercial insurance is another word for that, has
Okay.
to report colorectal cancer screening. So their screening rates are up in the 60s, high 60s to 70%.
Okay.
Whereas we know in Medicaid or Medi-Cal, we estimate it's probably in the 40s. We don't know what it is.
Okay. Okay. Thank you
Okay,
very much, Dr. Anderson.
sure.
Mhm, mhm.
Thank you, Dr. Njing, for that question as well.
You're welcome. Mhm.
I have a question, Dr. Headley. This is
Sure.
Felicia. This is Felicia Haddon. Question to Dr. Anderson in regards to an individual who may have taken a screening for the colonoscopy, and they discovered polyps, and they removed the polyps. What's the likelihood of the polyps returning and possibly either going into cancer?
Okay, that's that was early in the lecture, but I'll address the other one quickly. We know that sometimes the gastroenterologist, if it's a flat, large polyp, cannot get all the polyps. So it's not likely that the polyp would return, but if it wasn't completely removed, it can regrow. If you remove polyps, there are a set of guidelines based on the number of polyps and the size of the polyps, how often you need to do colonoscopy, because polyps, especially larger polyps, those advanced adenomas that I talked about, increase your risk of colon cancer, and you require more frequent. And we don't call it screening after that, we call it surveillance, because you become a high risk person. So now you're having surveillance colonoscopies.
Okay, so if the person had a family member that had a history and also developed cancer and went through the whole cancer treatment, the likelihood of that being genetic and possibly maybe hereditary, is that a possibility?
Yes, then they're no longer average risk. So, and the age of onset of the colon cancer or the polyps important. If it's less than age 60, you're more likely to have be at increased risk because of your relative, and it's a first degree relative in general we talk about, mother, father, brother, sister. But so that takes you out of the average risk and makes you at increased risk. And there is a set of guidelines on how often you should be screened. But in general, it's with colonoscopy. And as we talked earlier, general 5-year intervals, sometimes less. Okay.
Frequency 5 years, you say?
Yeah, on most people, yes. Some more often.
Okay. Thank you so much, Dr. Anderson.
You bet.
Thank you, Felicia, for your question.
Yes.
With that said, I will let Dr. Amalu take us out.
Thank you so much, Dr. Anderson. It's again a public pleasure for you to actually accept this invitation. I came in here, lectured us about the need for screening, which is important. We always need to go upstream, and you have shown that what has been happening in California. That's a good news for Californians. And what I need to also say here is that we need to also become part of the solution in the sense that we need to be participatory participant in this type of information. Take it in, share with your loved ones and family members to go screen. Once a year, it doesn't cost that much to do fit tests. You know, you screen, you do it every year. That will save a lot of lives. Yes. So that's what I need to say on this. And once again, thank you, Dr. Anderson, for coming in this show and presenting ways to prevent colon cancer or colorectal cancer. Thank you.
Okay, thank you all for your attention and questions. Thanks so much.
Okay. Thank
you. And remember, Papalog is all about healthy people, healthy discussion, and healthy
environment.